Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami for a weekly Monday afternoon Instagram chat. Today's topic is unexplained infertility. What is it and how do we treat it? And unexplained infertility is sort of a diagnosis by exclusion. When we assess a couple for infertility, on the male side, we want to make sure there's adequate sperm present. On the female side, we want to make sure that ovulation is taking place. We want to make sure there's good ovarian reserve. We want to make sure that the anatomy is functional, meaning that the uterus is normal and the tubes are open. And if all those things are acceptable, then we really don't know, short of putting a laparoscope in and looking for hidden disease, we don't know what's causing the problem with the couple not getting pregnant. And for pregnancy to occur, the sperm has to be ejaculated in the vagina. The sperm has to swim up through the cervix in the uterus and get into the fallopian tube. At the same time, ovulation has to take place on the female side. The tube has to pick up the egg, has to transport the egg down to the middle of the tube. The sperm has to find the egg and fertilize it. And once fertilized, that embryo has to be transported back to the uterus, where it then implants. And if all those things don't happen properly, then at the end of the day, you don't get pregnant. The problem is that we don't know at which point that process is broken down. If everything is going okay, we can confirm that ovulation is taking place. You can see that by ultrasound. You can presume it by ovulation kits or temperature charts or just symptomatic mid-cycle pain. We know sperm is okay and relations are taking place because we've tested that. And we know from a hysterosalpingogram that the tubes are open, and by AMH level or antral follicle count, that ovarian reserve is acceptable. So if pregnancy just isn't happening, it falls into this bucket of unexplained infertility. It doesn't tell us if the problem is that the tube didn't find the egg. It doesn't tell us if that occurred, but the sperm didn't find the egg to fertilize it. Those two things may occur, but the tube not transported back to the uterus. Or that may occur, but it's just not implant. And the problem is that the hallmarks of what we can assess is that ovulation did take place and pregnancy either occurred or not. And the things that occur in between those two endpoints are just unknown. So if you have unexplained infertility, what do we do about it? And there are two basic approaches to unexplained infertility. The first line approach is a trial of ovulation induction medication combined with intrauterine insemination. And I say combined because the combination of the two together work better than just ovulation fertility drugs alone, and it works better than just doing inseminations alone. And the fertility drugs that are used for ovulation induction can be either oral medications like Clomid. They can be what's called a mini-stim approach, which is a combination of clomiphene citrate or Femara, which is letrozole, combined with low doses of injectable medication, or injectable medications called gonadotropins. This is Gonal-F, Follistim, or Menopur, combined with intrauterine insemination. And pregnancy rates with ovulation induction and insemination are much better than doing nothing, but they're not giant numbers. They're not that high. With unexplained infertility and using an oral ovulatory drug like Clomid with inseminations, you'll see pregnancy rates of about 8%. With injectables, it might be 15 to 18%. And with the blend, about 10 or 12%. So it's a good first line approach. If you have other issues such as diminished ovarian reserve or the sperm count's not 100% normal, then those are all going to be contributing factors that will lower that expectation for success. If one doesn't get pregnant with a few cycles of insemination, or in patients who are older, if you're in your late 30s or early 40s, it might not be a great idea to spend 3 or 4 months doing intrauterine inseminations with fertility drugs, and it may pay to go more directly to in vitro fertilization as a means of treatment. And with IVF, what's done is you put on fertility drugs to produce multiple eggs. When you're using ovulation induction for insemination, we're trying to get preferably 2 or 3 eggs to ovulate rather than just 1, but we don't want 5 or 10. With IVF, it's a different approach. We try and use high doses of fertility drugs with the purpose of getting hopefully 15 or 20 eggs. And if you're 25 or 35, that's often possible. But if you're in your late 30s or early 40s, then it's not as likely for us to get that many eggs if there's more resistance to the ovary. So, but with IVF, you put on injectable medications. Over a period of 10 or 12 days, we monitor the production of the eggs by looking at the follicles, which is the lake of fluid that the eggs sit in. And in the middle of the cycle, we then remove the eggs. The eggs are fertilized in the dish, and 5 days later, some of those eggs will fertilize and develop into embryos. And if you look at them under the microscope at that point, they look like little soccer balls. They're called blastocysts. They have 50 to 70 cells in them. And at that point, the embryo can either be transferred into the uterus or can be biopsied and frozen for a future frozen embryo transfer. So what are the advantages of the latter? With IVF, you're going to see much better pregnancy rates than with insemination. With most women under age 40, with a single normal embryo going back into the uterus, we would expect about a 50% pregnancy rate. If they're not biopsied embryos, so they're not proven to be normal, you're going to see better pregnancy rates in women that are under 35 and not so great as pregnancy rates in women that are in their late 30s or early 40s. But IVF is always going to trump anything else we do as far as the possibility of success in a cycle of treatment. Why does IVF work better? Well, when we do fertility drugs with insemination, we're basically fine-tuning the system and sort of jacking it up a little bit. We're trying to get 2 or 3 eggs to ovulate instead of just 1. We know we're getting the timing perfect because we are timing the insemination within that 12-hour window when ovulation is supposed to occur. And we're getting the sperm closer to the eggs because we're basically activating the sperm in the dish in the laboratory and then inseminating up into the uterus. So the sperm don't have to, kind of battle that swim through the vagina and through the cervical mucus. So we're getting things closer to where they need to be, but things have to happen naturally. The sperm still has to find the egg, the tube still has to pick up the egg, the embryo has to be transported to the uterus and it has to implant. With in vitro fertilization, you basically bypassed all that. So we get the eggs, we fertilize them in a dish, we watch the embryos grow. So the only issue is when we put that embryo back into the uterus, will it stick or will it not stick? And that's the only issue. So we bypassed all those things that relate to sort of unexplained infertility. The issues of did the tube pick up the egg? Doesn't matter. Did the sperm find the egg? Doesn't matter. Did the egg get fertilized and start developing? Doesn't matter. Did the embryo get to the uterus? Doesn't matter. We're putting the embryo into the uterus. So the only thing is, will it stick or not stick? And that's why IVF bypasses all those other things that can contribute to unexplained infertility. So it's, the importance, take-home messages here is 1, it's important to have a basic evaluation, find out what's not working properly. 2, if we find something specific that's not working, we try and treat it. And 3, if everything looks relatively normal, then we've got 2 avenues to go down. One is use of ovulation induction with timed intrauterine insemination, and that can be with oral or injectable medication. And the second option is in vitro fertilization, which is certainly the go-to option if the inseminations with fertility drugs doesn't work, or maybe the first option in somebody who has long-standing infertility, somebody that's a little bit older, somebody that has some mild contributing factors such as a slightly low AMH level or a sperm morphology not being normal, anything else that sort of falls within that, bucket of unexplained infertility, but may have some other factors as well. So that's pretty much a summary of it. The two options: fertility drugs with insemination or IVF. If one doesn't work, we go to IVF or go to IVF directly. So I hope that was helpful. It gives a little understanding of what happens when everything appears to be normal but isn't. And certainly, even when everything is normal, if you're not getting pregnant in a timely fashion, it's time to let one of us help you along those lines on your fertility journey and get you a nice healthy baby as quickly as we can. So have a great afternoon. Stay safe, and I hope your Thanksgiving was wonderful. Take care, everybody.